Hello and welcome to Medisch Kompas, the medicine podcast from the Netherlands, where in each episode we delve deeply into a medical case or topic with leading experts and specialists in their field. Today with us we have Professor Dr. Iain McInnes. Professor Iain McInnes is the head of the College of Medical, Veterinary and Life Sciences and Vice Principal of the University of Glasgow. He also holds the title of Muri Head Professor of Medicine and Versus Arthritis Professor of Rheumatology. He is Director of the Versus Arthritis Centre of Excellence for Inflammatory Arthritis, a programme led by the University of Glasgow in collaboration with the Universities of Oxford, Newcastle and Birmingham. Additionally, he serves as a member of the Greater Glasgow and Clyde Health Board and is a trustee on the board of Versus Arthritis. Professor McInnes has held several prominent leadership positions, including past chair of the Forum, that's the Foundation for European Rheumatology Research, Scientific Committee. He led the European Roadmap programme, which is defining the research agenda for rheumatology in Europe over the next decade. He is also the past president of the European Alliance of Rheumatology Associations, EULAR. Under his leadership, the first Pan-European Rheumatology Research Centre was launched in 2021. His research is primarily focused on understanding the pathogenesis of immune-mediated inflammatory diseases. His work spans from fundamental discovery in immunology to clinical trials, including phase 1 and proof-of-concept studies, and leadership of pivotal phase 3 trials in immune biology. His lab has made groundbreaking discoveries that have supported the therapeutic targeting of several inflammatory cytokines. More recently, his research has centered on the role of myeloid cells in development of immune diseases. Professor McInnes has also contributed to various scientific advisory groups within the pharmaceutical industry, particularly in the development of novel immune-modifying agents. He has published more than 550 peer-reviewed articles with a H-index of over 130, reflecting approximately 100,000 citations. He is a Fellow of the Royal Society of Edinburgh and the Academy of Medical Sciences. In 2019, Professor McInnes was made Commander of the Order of the British Empire by HM Queen Elizabeth II, who we're actually conveniently sitting underneath right now, a photo of in the Concertgebouw where we're doing the recording. So, welcome.
Lovely to be here. Lovely to be here. Nice to see you both.
It's an honor to have you here.
We wanted to start off with a couple of questions to get to know you.
Indeed. And actually, the first question, it's one I always like to ask. What brought you to this field of medicine? What inspired you?
Curiosity. I wanted to know the answer. Why do people get immune disease? Actually, right at the very beginning, of course, I was drawn to the terrible, dreadful impact that arthritis and other immune disorders have on the quality of life of the people who are afflicted. I actually had family members with rheumatoid arthritis, and it's quite a common condition. Many of us will have that early contact in our professional lives. But I was drawn, of course, by the curiosity to understand why that had happened. Early in my medical student days, whilst the course was focused on training as a clinician, I spent a little time in the laboratory. I spent time working as an undergraduate trainee in immunology. And when I got back into clinic, it became very obvious to me that the underpinnings of many common diseases had immunological basis, including the most obvious ones, rheumatoid arthritis, psoriasis, psoriatic arthritis. So it's a combination of clinical concern, but mainly asking the fundamental question, why has this happened? And if I understood that, what could I do better?
I think to have that passion so early on is really, I find it intriguing. Not many people have that when you ask around.
And do you have a feeling that you're getting any closer to the answer after all these years?
Oh, absolutely. I'm several years closer. But let me pick up your first point. I actually think the passion is there in almost everyone. I really do. I am so impressed with amazing young people coming into medicine at the moment. Of course, the trick is for us old guys, as academic clinicians, to make sure that we don't extinguish the passion, but rather what we do is excite you. And truth to tell, sometimes, you have that thought experiment with your friends. Would you like to do this all again? Absolutely, yes. And, I'd love to have another go at it all, but having the technologies available now in terms of computing, molecular medicine, and of course integrating that, you probably will talk about it later on, but this whole concept of convergence science, I'm really enthused by that. So as far as I'm concerned, the bright young things who get into medical school nowadays do have that spark of curiosity, and appropriately nurtured, wow, the future's going to be amazing. Just as an aside, I don't think I'd get into medical school nowadays.
Why is that?
You're all so smart. The grades you need are really, really high, but that's just in passing.
Well, thank you on behalf of all medical students, actually. I think we haven't ever got such a compliment.
No.
We also have another question for you to get to know you. Do you have a recent book or film that you would recommend to anyone?
A recent book or film? Well, films are easy. Anything with a James Bond in there. Okay, so let's just get that out of the way. Indubitably the most important series of films ever made. Favorite book? Oh, there are way too many. I think probably I'm currently enjoying a book that I'll actually talk about in the lecture I'm giving tomorrow, The Boy, the Mole, the Horse and the Fox. I can never remember whether that's the right order. By Charles Mackenzie, which is just a series of modern wisdoms, observations in life. If you ask me to read something more in the classics, then that would be the work of Robert Burns. I'm a huge fan of Scotland's national poet. There was another very, very wise man.
And then, of course, now I have to ask which James Bond, though, because the books are one thing, but series is broad.
I know, it's so difficult, isn't it? You know, everyone loves Sean Connery, but as a fellow Scot, I've got to go for Daniel Craig.
Okay. Strong choice, I think.
Yeah. Would you like to introduce the topic of today, Henry?
Yeah, so today we're going to be talking about rheumatoid arthritis and psoriatic arthritis and the immunology behind this terrible disease. I wanted to start off with asking about, would you be able to give a quick overview of what the key physiological and molecular features are that characterize arthritis?
So let's start with where the textbooks commence. So they talk about inflammatory arthritis. And they almost always then start out with rheumatoid arthritis, which conventionally was considered the most common of the inflammatory arthropathies. Actually, that's probably not true. Probably gout is a commoner inflammatory arthropathy, particularly with the increased prevalence of metabolic syndrome and other risk factors. But if we stick to the immune-mediated diseases, rheumatoid and psoriatic arthritis, rheumatoid is a disease of any age but median onset in the middle years, 40s and 50s. It's a disease of the joints of the synovial membrane. It's a disease with numerous comorbidities, accelerated cardiovascular disease, accelerated psychological morbidity, depression, suicidal ideation, so-called cognitive dysfunction, hugely disabling, fatigue. But it's a disease also of accelerated pulmonary disease, increased risk of some cancers. So in a sense, arthritis does it a disservice. It is a disease of the whole person. Now just think in contrast for a moment about psoriatic arthritis. It was, until about 15, 20 years ago, mainly considered rheumatoid with a rash. It was very rarely differentiated in the main textbooks. Most clinicians would simply take the patient has psoriasis and some swollen joints, and I'll treat them just as I would as if they had rheumatoid arthritis. But that, as it turns out, was a fundamentally misguided approach to the treatment of that disease. So in fact, it's easier when you're discussing them to think of them as quite distinct conditions. Putting them together, I think, in the minds of clinicians can often lead to clinical errors, just to mistakes, because we do become confused when we treat one with the other. So I would urge right from the outset that we separate the diseases. They have quite distinct pathogenetic features. And nowadays, with the medicines that we have available, they also have quite a distinct strategy of care that is required.
And do these distinct characteristics contribute to unique challenges when you're looking to developing treatments or researching essentially their genesis?
Oh, they absolutely do. So let's start with the distinctions in terms of developing new medicines. And let's think even more deeply, how do we go about developing a new medicine? Well, back in the olden days, the medicine was developed against a given pathway. And then the medicine looked for a disease. And that led to quite successful introduction of a number of medicines across, particularly cardiovascular, some oncologic conditions. There's too much proliferating cell, let's create a cytotoxic drug. There's some rationale in that. But in the immune-mediated diseases, and rheumatoid in particular, that was a very partially helpful, but in my view, misguided approach. Think back to the history of the medicines that were introduced for the treatment of rheumatoid arthritis. We used to use non-steroidal drugs broadly. We still do occasionally. Glucocorticoids in the middle of the 20th century won a Nobel Prize, and for a short term were hailed as the cure for rheumatoid until we realized that they cause diabetes, hypertension, osteoporosis, really abnormal weight gain. And so suddenly the cure became the curse. And it wasn't really until the 1980s that we borrowed a drug from the cancer field, methotrexate, and demonstrated that there was at least some benefit to be had. And that benefit came in several forms. It came in the reduction of pain and swelling. It also came in the protection of joints from damage. That's a really interesting and important concept. Protecting joints from damage is the origin of the so-called phrase disease modifying. Now, you'll actually hear disease modifying used across many disciplines in medicine now, but it was originally coined to define that medicine given to someone with rheumatoid, where the medicine not only improves the symptoms and the signs, but also prevents the underlying damage, the loss of cartilage and bone, which is so disfiguring and functionally impairing. So that's the history up until about mid-1990s. But at that point, that's when immunology kicked in. At that point, we started to understand the immunologic mechanisms that were dominant in people with rheumatoid arthritis, the most obvious and important being TNF, tumour necrosis factor. What a misnomer that is. It should have been called master immune regulatory cytokine, but it wouldn't have been as catchy as TNF. So, of course, it was originally described as a cachexin. It was a molecule that was released in advanced cancer and is, even to this day, a molecule that we think is most likely causing the terrible weight loss and debility of metastatic disease. But TNF turned out to be the pivotal primary inflammatory cytokine driving immune-mediated disease, and particularly rheumatoid. And of course, when you couple that with the availability of monoclonal antibody therapeutics, anti-TNF antibodies, that was the pivotal moment. And around about the year 1998, 1999, we had the advent of biologic therapeutics. So what was different about that was that these were not drugs taken off the shelf looking for a disease. This was a disease whose mechanism was defined looking for a drug. And that's a fundamental paradigm shift for at least us as rheumatologists. And that early success with TNF blockade was followed by drugs targeting a whole range of inflammatory cytokines in people with rheumatoid, IL-6 being the first and probably still that which is most alike TNF blockade. We also went after cells. We depleted B cells. Rituximab was the drug that achieved that. We interfered with checkpoints, commonly now known about in terms of cancer modulation. But remember, the immunology, rheumatology community got there first. We were modifying checkpoints to improve people's lives with rheumatoid arthritis. And then finally, at around 2014, 2015, we found small molecules that were capable of recapitulating the benefits of these large biologic interventions. The small molecules are, at least the first raft that have been successful, were targeting the Janus kinases. These are really crafty molecules. They sit on the membrane of a cell just adjacent to a cytokine receptor. And even if a cytokine binds to its receptor, the kinase inhibitor will prevent the signal getting on into the cell. And so the advent of kinase inhibition. But all of these were disease pathogenesis understanding, looking for mechanistic intervention. Well, look, if you followed me so far and you've not dozed off, you will vaguely remember that you asked me whether the same rule should apply to rheumatoid and psoriatic arthritis. Well, the answer is it absolutely does not. At the very first round, we gave TNF inhibitors to people with psoriatic arthritis, and actually a lot of people responded, which was wonderful. And the immunologists thought we were in for an easy ride. All we need to do is to choose the same target, develop more targets, pick up the immune diseases, and they will fall over like dominoes. So when an IL-6 inhibitor was given to people with psoriatic arthritis, there was real distress because the patients didn't respond. And that was the first clue that we had a serious thought block. So rheumatoid and psoriatic arthritis turn out to have quite fundamentally different immune pathogenesis. Whilst they have overlapping genetics, there are distinctions in their genetics. whilst there are overlapping responses to some therapies, TNF blockers being the best example, I've given that to you already, there are actually quite unique therapeutic inputs that work very well in psoriatic arthritis. And here's the real kicker, they don't work in rheumatoid. So when we block IL-17A or we block IL-23, we get very nice responses in psoriatic arthritis. Indeed, the skin and the joints improve dramatically. But we get no response that is worthwhile in people with rheumatoid. So what do I take from that? Well, I take first of all that the immune system is complex. And by the way, as an aside, I'm very glad it is. Think of the billions of microbes out there that are potentially threatening us in the next few days. It's a good job that our immune system is complex and capable of extraordinary molecular agility. But I take it also that it behoves us, and even more importantly, all you young clinicians, to think really carefully about how you analyse and break down disease states before you choose novel therapeutics. With the technologies we have available, the molecular analysis, we will be able to create orphans out of really rather complex diseases. What I mean by that is we'll choose those distinct subgroups of patients who are capable of responding to quite discrete molecular modes of action.
Yeah. I think it's fascinating to hear about how a shift in perspective on how you approach disease can lead to such dramatic differences in outcomes. And I'm sitting here thinking now, in what other areas of medicine could this be applied, and when are we missing that change in perspective in certain diseases?
So rheumatologists are amongst the nicest clinicians in the world.
Okay,
and let me tell you why I say that. It might even be true, present company accepted. But many rheumatologists entered rheumatology at a time when there were very few effective therapies. So this was a generation of doctors who entered medicine committed to treating chronic, lifelong diseases with very inadequate therapeutics. That takes a very special kind of personality. And you see very similar traits in oncologists who take on really life-threatening, challenging diseases. And in fact, one of the ironies is that oncologists are often trying to create a chronic disease out of an acute cancer. They'd like actually to make that something that is going to remain in remission or controllable remission for many years to come. So the first thing to say is that rheumatologists would never, I think, say that our field had informed others. We might gently point out with a smile on our face that many of the medicines that originated in rheumatology are now used to treat psoriasis and dermatology, inflammatory bowel disease and gastroenterology. Some of the therapeutics we've developed in the connective tissue disease field, I think will probably have reference in some of the major neurologic inflammatory disorders. But it probably goes even beyond that. I'm actually an anti-ologist. I just made that word up. But let me explain what I try to infer. I no longer think that defining disease by the simple clinical presentation is satisfactory. I think we now have a generation of patients who deserve a molecular diagnosis. They deserve that we think really deeply about the underlying pathogenesis that afflicts them. And then we as clinicians make rational pathogenetic interventions on the basis of that understanding. Now, you'll sometimes hear that very grandly called precision medicine. Apparently I do precision medicine, and apparently I have been doing it for many years. That came as a bit of a surprise to me. I think that is an overgrandiose term with deep apologies to learned folk who have written a lot about it. At its simplest, modern molecular medicine allows us to deconstruct the disease, consider the appropriate intervention, and reconstruct homeostasis or health. And that's the model that I think rheumatologists, dermatologists, gastroenterologists should be looking for when they're treating the immune diseases. And if we take it to that logical conclusion, then we should be working as a single discipline focused on the immune-mediated inflammatory diseases. Of course, we will have our tissue-specific expertise. But oncologists are quite happy living as a single oncology discipline with subspecialty interest in lung cancer, in breast cancer, in colon cancer. So why wouldn't we do the same thing in immune disease?
No, it's a fantastic thought to have, and I think it's something I would be interested in discussing with my colleagues in the oncology department about the approach to why we do it. And I think it is also, like you say, a lot of the time an uphill battle, and it's a losing battle. And yeah, I can definitely see a very effective overlap for learning the lessons from fields that are successful in implementing that appropriately.
Just in passing, I think we usually consider that we are learning the lessons from oncology. I think oncologists have really pioneered and led the way in molecular definition of disease and clinical decision-making that follows that. In a way, they've had to do that because they're dealing with mutations. And, the old idea, one mutation, one tumor, that turned out many years ago to be an incorrect understanding. There are many mutations and very volatile mutations in any given tumor, in any given patient. And that requires the oncologist to be extraordinarily agile in the way in which they consider the molecular pathogenesis that they're treating. So in truth, the oncologists are my molecular heroes right now, but I'm not clever enough to be an oncologist, so I'll stick to rheumatology right now, if that's okay.
I was wondering because you had the thought about, but how would you implement it? The new generation of doctors on the molecular level?
So that's a really good question. You're asking a question about the strategy of care. So a lot of focus that we hear about nowadays is what are the medicines I'm going to use? What dose? How much? Particularly for young doctors, we spend a lot of time thinking about medicines. But we do spend much less time thinking about the strategy, the approach that we should use. Well, let's deal with the present. At the present, we should make a formal clinical diagnosis. We should, as far as we can, understand the pathology that underpins that diagnosis, and we should then make the appropriate therapeutic intervention. I think for a general medical audience, the intervention should be driven by national or international recommendations or guidelines. Now, that sounds like a defensive statement on my part. I'll come to what I'd like to do 10 years from now in a moment. But at the moment, the correct advice is there are recommendations out there which are heavily evidence-based, and those are the ones that we should all follow. So now everyone's written that down and remembered that. Let's imagine a virtual clinic 10 years from now, where the patient will consult online, AI algorithms will weed out the illness behavior from the informative, clinically relevant facts. The patient will pop down to their local supermarket and donate a blood sample, which will be immediately submitted to a detailed disease-focused biomarker screen. A series of recommendations for the medicines that might now be most appropriate will come up and will go virtually to the patient's family doctor, who will look at them, evaluate, make a judgment. There has to be clinical judgment in all of this, and then a therapeutic decision will be made. Now, that would be for general internal medicine. You could imagine a form fruste of that arriving even sooner for immune-mediated inflammatory diseases. Why do I say that? Because after COVID, we have virtual clinics. We have huge biomarker panels, not yet optimized. That's where the work has to be done. We've got to do this and validate over the next 5 to 10 years. Virtual prescribing, we already do that. Virtual trialing, we already do that. So a lot of that so-called mythical future is here already. We just haven't put it together.
And then a question that comes into my head is we're talking now a little bit about how systems of care are organized, and this seems quite a dramatic overhaul on how we actually approach medicine, especially looking into the future. Now we have huge problems with the aging population, and in the next 10, 20, 30 years we'll be essentially needing to see that. And do you think that's something that will also be able to meet the goals of being cost effective and providing good quality of life alongside good medicine? Do you think they're compatible?
So systems of healthcare vary a little across Europe, and let's just stick to Europe, shall we? But the universal commonality is that they're all struggling to cope.
Yeah.
And we often talk about the burden of age, but the burden of age should be the joy of age. Healthy living is one of the triumphs of the last 50 years of modern medicine and other elements, of course, in society. So we should celebrate rather than denigrate it. We probably, my own view is that as we make clinical decision-making more straightforward, more often accurate, and we improve the quality of healthy life years lived, in due course, the healthcare burden will reduce. But at the moment, I'm afraid the statistics don't have that projection. The statistics tell us that the healthcare burden is going to increase. And look, there are many, many different approaches to that. The obvious one, and I think the simplest one for a conversation like this, is to refocus on prevention. We've got to start thinking about early identification of disease, clear recognition of those antecedents, and then act and address those. And this bit is not difficult. Obesity. We have got to get to grips with the management of obesity. Smoking, public health hazard now recognised for decades and decades, and yet still prevalent in different parts of Europe. And I guess, in a sense, maybe life interventions are going to have to start in childhood and adolescence. Maybe we're really going to have to think about the totality of the healthcare experience. And if you want my craziest idea of the week,
yes, please.
Please.
Well, why don't we think about designing our environment, designing our cities to be anti-obesity, to be anti-cancer, to be anti-cardiometabolic risk? You know, I'm here in Amsterdam with you. I've narrowly avoided 4 or 5 fatalities, and that was in the first 5 minutes of walking past the bicycles there. But look at this as a city that's designed for people to exercise to and from their daily activities. Compare and contrast that with many of the cities in other parts of Europe where being on a bicycle is a really, really dangerous thing. But we could go well beyond that. We could really think about the design of schools, the design of workplaces, the design of leisure, the availability of leisure, the encouragement of leisure, thinking about work-life balance, virtual working, and real, true face-to-face working. So how are you going to achieve that nirvana? Well, it means doctors are going to have to work with urban planners, who are going to have to work with geographers, who are going to have to work with social scientists, who are going to have to work with economists. That is, I mentioned convergence science to you earlier in our discussion. That for me is the sweet point when the different experts come together, each contributing their capability and knowledge skill set to focus on the challenge, which is to change behaviors. One of the hardest things you can possibly do for a human.
Yeah, and then to summarize that, what we're looking at is fundamentally organizing a society around care as an outcome that's prioritized.
Well, we're organizing a society that is fulfilling for its members, that is self-perpetuating for that society, and increasingly is sustainable. And we're going to have to feed in the whole concept of planetary health. The idea of we as the selfish species simply has to change. Otherwise, the selfish species will do away with itself. And so conceptually going forward, a society that does not place the well-being of its future is going to be a society that's in trouble. I was recently speaking at a wonderful meeting in the South Island of New Zealand. And I went to a Maori medicine session. I would recommend to all of you, whenever you go to a meeting, go to sessions that are different from your own discipline. That's when you actually learn things. And the Maoris, although I've subsequently read that several different indigenous cultures claim this saying, but the Maori medicine principle is that we who own the present have only borrowed it from our children. And if you stop and think about that, we love our children and their children to come. So the responsibility we have in creating a society, yes, it must be health conscious, it should be well-being conscious, but it has to be planetarily conscious also. And so, hey, there's a lot in there. But when we start to set the ethical parameters around medical development, we talk about an aging society. Well, an aging society should be one that is ethically designed to allow healthy aging. There isn't any point in living to 105 if you spend the last 20 years with a dementia-type state. That's neither good for the individual nor for the poor souls who end up doing the caring. So that in turn means that you, this young, next amazing generation of physicians, are going to have to take on board not just relentless progress, but thoughtful, purposeful progress. And I hope that we've given you some of the tools in my generation to achieve that, but it will need your wisdom and your vision to really refine that model as you go forward. I wish you well.
I was wondering, do you see it as a possibility? Because right now we live in a society which is not designed for long-term and good living, and to do the switch, because at some point there has to be the switch to get to this nirvana we were discussing. So how would we get there?
I don't have answers, but the first thing I would say to you is that I don't think the gravity of the task should dissuade us from the journey. I don't think we've got any option. That's the first thing. Secondly, if we start on our children and young adults in terms of lifestyle, behavioural modification, then we will already be saving the healthcare burden 40, 50 years from now. And we need to do it now. So that imperative is very difficult to avoid. Let me go back into my clinic. Some of the easiest patients to persuade to come into our trials are the family members of people with rheumatoid arthritis, because they've seen what it's done. They've seen what this disease can do. So they will come in and help us with our research. They'll volunteer samples to help us in genetic studies. And some who maybe have evidence of pre-disease will submit themselves into clinical trials. Believe it or not, we're doing clinical trials right now to prevent the onset of rheumatoid arthritis. We're doing trials to prevent the onset of rheumatoid arthritis. If I'd said that even 10 years ago, people would have thought this poor man's been out in the sun too much. Not a lot of sun in Glasgow, but hey, there we go. What little sun in Glasgow was too much for the poor soul. But when you start recruiting people for those kind of trials, the people who've seen the direct impact of the disease. And so probably what we have to do is think prevention, but think about publicising the consequences of lifestyle behaviours that lead to ill health. And that must move from a punitive message to a positive, encouraging message, which is why, back to the idea of convergence science, we have to bring the social scientists, behavioural scientists, we have to bring heavy industry in here. Actually, I believe heavy industry, and by heavy industry, I mean particularly those who are pushing highly processed foods, those who are still creating high carbon outputs. Actually, if you talk to those industries who have a clear 20, 30-year vision from now, they need to see change as well, because it's their marketplace that's getting accelerated cardiovascular disease, accelerated cancer, and so on and so forth. So no simple answers here. I apologise for that. But other than we need to think and work together, the idea of the separate silo mentality simply has to stop.
In our rapidly developing world of research, where does the balance between subject-specific experts and generalists lie?
We will always need absolute subject-specific experts. But we also need those who are prepared to move from one discipline to another. But just to reassure you, those individuals have always existed. I would suggest to you respectfully that the future belongs to people who ask the best questions. Simple knowledge is going to become relatively straightforward as a commodity. Think ChatGPT at the moment. Think what that'll be 10 years from now, unrecognizable from today. Finding facts, working your way through facts, collating and assimilating facts is going to become relatively facile with the predictive models that modern computing can provide. The really clever people were the ones that ask the right questions. And I think, what would be a correct question? Well, the correct question might very well be, how am I going to control weight in people who seem to be reluctant to change their behaviors? Well, I'm going to change the life environment in which they exist. I'm going to work with industry. I'm going to work with the behavioral scientists. I'm going to work with the educational facilities. I'm probably going to work with urban planners. I'm going to make it easier and easier and easier for those to make choices that are pro-health. It's about encouraging We all know that as doctors. If you tell someone not to do it, that's often a message that is difficult. But if you tell someone, here's what you can do to help yourself, to help those around you, to bring about a better outcome, it's amazing how often that positive advice will lead to a positive response. It's a shift that's essential. It's a shift that will either be imposed upon us, but as I say, if you ask the great questions, you'll lead the charge.
Well, we've discussed this now at length, and since you're being whisked away in about 11 minutes, I was wondering if there's something you find important to share with us.
What would I say to a young doctor? What would I say to my younger self? Or what would I say to any young doctor? First of all, to encourage you that you'll get there. Almost all of us in medicine spend a lot of time thinking this is going to be really hard. I don't even think I'm going to pass. Will I get my medical degree? Will I get my fellowship? Will I ever find a specialty? Will I ever find a job? And I guess the first thing I wish someone had told my younger self was the answer to all of those is going to be, it's be fine. Yes. So that's the first thing I would say to you. Secondly, and we've touched on this already, start to think about the questions that really motivate you. What is it that excites you in the morning? What would you like to know the answer to by the afternoon? And that'll give you a strong clue as to whereabouts in medicine you probably want to land. Don't resist the urge to be excited about some areas of medicine over others. And just in passing, do not be pushed into making early decisions about what you want to do and where you'd like to land in medicine. When I look back, when I was in medical school, I wanted to be a general practitioner, probably working in the East End of Glasgow. That's how focused I was. I've ended up as, well, I suppose my clinical hospital practice is in the East End of Glasgow. but
Close enough.
But I was miles away from being a general practitioner. Wasn't clever enough. General practitioners have got to be so smart. They have to be the masters of all of the areas of medicine. That's a real skill, a real talent. But I wouldn't be rushed into making a decision. Many people, of course, we're threatened, aren't we, by our colleagues who say, "Oh, I know exactly what I want to be. I'm going to be a cardiologist. I'm going to be flying in a private jet to get to my yacht so I can do my other clinics." Almost all the people in my med school year who said that ended up, ironically, as GPs in the East End of Glasgow. And that is because we all change our minds. And you know what changes our minds? It's our patients. We think we're in control of what we'll be interested in, but actually we aren't. It is our patients and the challenges that they give to us and the solutions that they seek from us that will guide our interests and will ultimately give us our choices of the appropriate specialty. So honestly, just don't rush, take your time and let medicine decide for you.
Go with the flow.
Yeah.
Yeah.
Also keep curious, I think.
It's wonderful.
Curiosity, one of my other favourite words.
It is wonderful to hear because there is a lot of push and drive and to be doing
pressure.
Extra. And
of course there is. And who's giving you that? That's the system that's giving that. They're short of doctors.
Yeah.
Resist that pressure.
Well, not in the Netherlands.
Oh, too many doctors in the Netherlands.
Too many doctors in the Netherlands.
You can never have too many doctors, in my opinion. But
I think it's more about funding than doctors.
Yeah. I had a final question then. Also, that what excites you the most about the future in your area of research, and maybe also in your perspective on the future of medicine? So
in rheumatology, I'm excited about. First of all, I'm excited when I look back over the last 2 decades. When I went first as a consultant in my clinic was full of wheelchairs. And we don't have wheelchairs anymore. We have patients who used to literally be unable to get up out of their seat or they're off their bed. And now it still happens, but it's a very rare occurrence. So I think the first thing is to allow ourselves just a little celebration for 2 decades of incredible progress in rheumatology. Of course, I am Scottish. So that means I'm never satisfied. So looking forward, what are we looking for? In my discipline, I think we are going to identify subsets of our diseases that we can effectively deliver cure. Not for all of the patients with any given disease and not for all of the diseases, but there are now identifiable subsets of people who have immune-mediated inflammatory disorders for whom we can give such highly effective therapies that we can really look in the long term at certainly at drug-maintained remission. And much of the work that's going on in my lab is focused on drug-free remission. About 2015, I was on a train. It was delayed. They always are in Britain. And I was reflecting on what we had achieved, because by then I guess I'd been working about 20 years in the lab. I was reflecting on what we had achieved by studying active rheumatoid arthritis. And it occurred to me that we had never studied inactive rheumatoid arthritis. We'd never actually studied people who were in remission. That was a curious oversight. And so we flipped the whole group. So instead of asking what happens when the disease is on, the question became, what happens if the disease is off? Now, believe it or not, there were almost no papers in the literature describing whether someone in remission has absence of disease or restrained disease. Now, the difference is really critical. If someone is in remission and there's no inflammation in the joint, that would suggest absence of disease. If you take someone in remission and look in their joint and actually see that there's still a cellular process there, but the process is saying switch off, not switch on, then there's a huge clue as to how we could intervene therapeutically. Turned out that it was the latter, not the former. We found cells in the joints of people in remission that were actively down regulating, suppressing disease. Those are extraordinary cells. And of course, you know what we've done. We're using single cell and spatial biology to try and understand at the very basic molecular level what they do, how they do it, and when they do it. I think that's a rich treasure trove of new therapeutic opportunities. So I'm actually really optimistic that in rheumatology, we're going to be talking about remission maintenance instead of active disease control. We should be doing that already, and we certainly will be in 5 years' time.
Yeah.
Well, I think that's a wonderful way to conclude our recording, and I think we have to from the boss as well. Dr. McInnes, I would like to thank you enormously. It's been a huge pleasure and honor to have you on the show and to discuss your ideas with you and to hear your thoughts about medicine and the field that you're clearly very passionate about.
And the future as well.
And the future as well.
Yeah.
The future is going to be great, guys.
Yeah.
It's in your hands, and you guys are amazing. So what could possibly go wrong?
Yeah, but the way has been made.
The way has been made, yeah, indeed. So thank you so much, and I hope you enjoy the rest of your trip in Amsterdam.
Thank you.
We'll see you tomorrow.
You will. It's been my absolute pleasure to join you. Thank you very much indeed.